Hi, good morning. Welcome to Pediatric Grand Rounds, and our brand new room looks more like a 70s room. All right, today's speaker is Dr. Asma Habib. She's one of our relatively new faculty members in the Department of Pediatric Cardiology. She trained at Virginia Commonwealth University and went on to complete a combined med-peds residency at Eastern Carolina State University with pediatric cardiology fellowship training at Raleigh Children's Hospital at Indiana State. She completed advanced training at Seattle Children's Hospital. She has numerous publications and presentations to her name and was an invited speaker to the Western Society of Pediatric Cardiologists. She was also the recipient of the Red Shoes Award for contributions to pediatric-centered care during her fellowship. Please welcome Dr. Habib.
Good morning, everybody. Thank you so much for having me here. I'm super excited to talk to my peds people. I gave medicine grand rounds 2 weeks ago, and it was good. So I was like, I know my peds people are going to be a lot more excitable and just going to be so much fun because peds better. Little plug there. So today we're going to be talking about hypertrophic cardiomyopathy. What led me to want to do this is that we had a case a couple months ago that came out of nowhere, and I was like, wow, this is terrible. We should actually learn about this and just spread this information in the community. So this is not designed to be a talk for cardiologists. Sorry, Dr. Whitley, I know you're in the audience. Trying to make it simple enough to understand so that way everyone's not like, oh my God, cardiology, I never want to rotate there. I have no disclosures. No one with that Carilion paying me. If anybody wants to pay me, that's great. So wise words. At a cardiac arrest, the first procedure is to take your own pulse. I'm not sure if the residents of Red House have God, but yeah, this is like a really important rule. So today we're going to basically define and understand the pathophysiology of hypertrophic cardiomyopathy. We're going to describe some clinical characteristics and what to look for on exam, and we're also going to discuss treatment challenges. This is a graphic I got off the internet. I don't know who this young man is. I'm not sure if this is staged or if this is real. My guess is it's probably a pretty good chance that this is real. I'm glad I've never seen this except for in the hospital, but this is something that I think we're living with across the country. How many reports do we hear? This kid here, this kid here. I mean, I've heard of like 2 or 3 alone near Roanoke, and there was a couple in Lynchburg. And so this is kind of just to frame us about why we're thinking about this and why we're talking about this today. So I'm going to start with a case scenario to frame everything. Our patient was a 15-year-old young man, no real past medical history, so he was healthy. He didn't go to the doctor for a couple years because he didn't need a physical or shots. He was not a regular athlete, pretty good health, baseline, played some video games. He was running suicides in gym class. They called him the shuttle run where I went to school, so I've never heard it as suicides, but I just thought that was a terrible name, so I would put it in there because that sucks. Let's not call it that. He had a witness sudden cardiac arrest. So obviously your brain starts cranking, you're going, hey, what's the differential, what's going on? Yeah, it says hypertrophic cardiomyopathy, but residents can learn something. So either primary arrhythmia, heart failure, valvar disease, myocarditis, an anomalous coronary, something non-cardiac, or HOCM, as we're talking about today. Just before we get into all the nitty-gritty of everything, here we can see a normal, nice heart, and then we can see a hypertrophic heart. This is showing a heart with asymmetric septal hypertrophy here, a small left ventricular cavity because all the muscles taking up all the room, and changes that we can see with hypertrophic cardiomyopathy. If you'll pay attention here, this is the anterior leaflet of the mitral valve, and you see how it's almost like kissing the septum. So just kind of remember that picture in your head. This here, we'll visit again, this is the left ventricular outflow tract, or the part of the heart basically where blood ejects out to the aorta. So remember, for cardiac anatomy, all the venous blood comes into your right atrium, dumps into your right ventricle, goes to your lungs, you breathe in and out oxygen, go back to your left atrium, to your left ventricle, then out your aorta and to the body. So his story is rather remarkable. I think all the doctors who were involved at some point or another started crying when they heard his story. So classmates run to get the school nurse. They get the principal because she sees everybody's running. The nurse gets there. The kid has a very faint pulse, surprisingly. Then respirations become agonal. There's no pulse at that point. CPR is started immediately by a nurse, and luckily a coach who was across the room in the gym, basically, who had some EMT, like significant medical training. So this guy was lucky. Someone was watching over him. Principal goes and runs, gets the AED, notifies the family, calls EMS, the AED is placed, no shock advised. So maybe this guy was probably asystolic. What do you do? Back on the chest. Remember, good CPR. Doesn't matter. That device said no shock. Back on the chest. Good bystander CPR will save your life. EMS arrives within 10 minutes of the start of the arrest, and then you see this awful, scary rhythm on the monitor, ventricular fibrillation, disorganized, chaotic, polymorphic, wide complex rhythm. He has return of spontaneous circulation with just one shock. Luckily, he's not really awake in the ER. He's not awake while he's in the van going to the hospital, trying to figure out from the family afterwards, when did he wake up, what's going on. He starts actually coming up and fighting in the ER, which when I heard that, I was like, okay, that's good. So he's in there, because I saw him once he was sedated. On exam, he had a harsh 3 out of 6 crescendo, decrescendo systolic murmur. He had some diagnostic workup done. Labs were fine. Head CT was fine. He arrested, so I think head CT was obviously what they needed to do. Chest x-ray with right-sided aspiration. EKG is diagnostic. Echo is confirmatory. We're consulted. So on chest x-ray here, drawing your attention to right-sided aspiration. Also, big old heart here. That's not normal. Over half the cardiac roulette. That's big. Normal EKG here, just to reference everybody. So look here, we've got a nice P before every QRS. We've got nice upright T waves everywhere. We've got good progression of our R waves. This is a nice, normal, happy-looking EKG. This is his EKG. I don't know if anyone can start to see that there's things abnormal here. I'll give you guys a second to digest that. Okay, so there's T-wave inversion in the lateral lead, signifying that there's some kind of ischemia going on. There's left axis deviation. One is up, AVF is pointing down, so leftward axis. There are big Q waves, and he's got left ventricular hypertrophy criteria as well. Now, looking at what a normal heart looks like on echoes, I know a lot of you guys don't look at echoes. So this is a nice, normal, happy teenage heart. Nice thin ventricle here, nice looking mitral valve, here in 4 chambers, the right side, the left side, here the left ventricle. You can see the walls over here, not a very thick heart. All right, so comparing this, now let's jump ahead. This is this kid's echo. This is a very, very, very thick heart. The heart is basically trying to obliterate the cavity inside of itself. The walls are basically slamming against each other. You can see that here in the bottom. And you can see here, this is a color flow Doppler image. Basically, the most important thing, all the flow here is turning kind of a yellow color. If it was nice laminar flow that was escaping the heart easily, it would look like a blue color. The yellow signifies the blood is really trying to get out of this heart because it's basically collapsing on itself, kind of like Indiana Jones in the Temple of Doom, trying to get out. Here we can see the heart as if we're cutting it in short axis, so as if I'm slicing a loaf of bread. Just to draw your attention, that's thick. That's not normal. That's not normal. Here also, again, this is the piece de resistance. You can see here's the septum, super thick. There's our mitral valve almost trying to kiss that septum as well. So he's admitted to PICU. He's intubated and sedated. Our PICU team does a really nice job. He gets what's called therapeutic hypothermia or targeted temperature management. I'm sure you guys have seen this in the NICU with perinatal asphyxia where we cool down the baby. Basically, the goal is to prevent neurologic perfusion injury after you get return of spontaneous circulation. You cool the patient down to a fairly chilly temperature, 32, 34 degrees Celsius. Different places have different protocols. You keep them cool for a certain amount of time, about up to a day, and then you rewarm them just half a degree an hour because rewarming can cause a lot of other challenges, coagulation issues, other problems. You don't want to take somebody right from cold and warm them back up. So we did this hopefully to protect his brain. So this whole time we're going, okay, hopefully he'll wake up. Hopefully he'll wake up. Remember, I've got like an awful crying family in the room that we're trying to console at the same time. This is awful. There's several family members. This is a huge shock. Their kid was completely healthy. And I'm sitting here with the PICU going, okay, we'll see, we'll see, we'll see. And that's a terrible feeling, you guys all know. I hope this kid wakes up. So he developed hypotension in the ICU while he's intubated and sedated. He started on a norepinephrine drip. Norepinephrine increases your contractility a lot, so it squeezes the crap out of your heart, and also it will help increase the systemic vascular resistance to bring your blood pressure up. He gets another echo, which basically shows his heart's almost trying to collapse in on itself. He gets some acute intervention, so we give this guy fluid. This cavity is small. I need to stretch it apart. What can I do? Give preload. I have to give IV fluid. So we're literally sitting by the bedside dumping 2 liters into this kid. I'm going, okay, we need more fluid, and then Dr. Powell's on the other end going, oh, protect the lungs, don't forget, we don't want to give him pulmonary edema. I'm like, keep going. But we eventually reached a balance. We also switched his pressors over from something that was not contracting the heart to something that was resisting the heart from being collapsible, basically using phenylephrine. Phenylephrine just squeezes your arteries, brings your blood pressure up, and allows the heart to try to push against something. So it's almost like stenting that left ventricular outflow tract open, not allowing it to collapse on itself, and we got his blood pressure up. He was on Dexmed for sedation, which has a desirable side effect of bradycardia. That was good. We put him on Dexmed in order to slow his heart rate down, to decrease how hard the heart was slamming against itself, and help get better filling and better output. So he wakes up post hypothermia, neuro intact. He's got a lot of PVCs and non-sustained VT on the monitor. He gets super tachycardic with activity. We put him on a beta blocker, treated for aspiration pneumonia, gets transferred to another institution that does pediatric EP procedures, and gets a defibrillator, eventually goes home after about 2.5 weeks, still trying to regain his memory. But I will tell you, when he woke up in the ICU, he came up fighting, and all of us were, there's nothing short of tears. I mean, seeing this neuro-intact kid wake up, thank goodness. He was a little bit sedated and funny because of his sedation, so we were trying to calm him down because he was panicking, and in all of this, we were saying, you're a nice kid, oh, you've got, you know, just trying to calm him down. He goes, yes, I know I'm pretty. It was just awesome. He doesn't remember a word of this. He's the shyest person, so it was just funny. Patient follow-up, thank goodness he's doing okay. His symptoms are controlled. He's at a Holter. He's not having a lot of VT in the background. He's seeing a therapist because he tried to die, so I think that's a good idea. He is trying to keep as best hydrated as he can. He's got genetic testing that's positive for an MYH7 mutation, which is one of the most common mutations that you see in the disease process. It's a Sacromeric mutation gene. So, all right. I thought this was a fun graphic here just to kind of tell you about the types of cardiomyopathy: restrictive, where the heart doesn't relax as well; dilated, where everything's just burned out and it's very stretched, which is the most common type of cardiomyopathy we see; and then hypertrophic. And I thought it was really cute that they made like the left hand and the left eye bigger because they're thick, so it's a little bit asymmetric. That was a really cute cartoon. So hypertrophic cardiomyopathy is the most inherited cardiomyopathy, the most common genetic form of heart disease, also in the past known as idiopathic subaortic stenosis, hypertrophic obstructive cardiomyopathy. There's also hypertrophic non-obstructive cardiomyopathy. The goals are for early recognition, timely diagnosis, initiating treatment, decreasing the physical and psychological effects, because there's not really a cure at this point. So characteristics of diagnosis, there's a lot of different fine criteria, but the major things that have been defined in the literature: left ventricular wall thickness greater than 15 millimeters. Normal posterior wall thickness in like a teenage adult-sized person is about a centimeter. Family history, you're going to be a little bit more keyed in, okay, I've had a first-degree relative with hypertrophic cardiomyopathy greater than 13 millimeter thickness. Like we said before, remember the LV cavity size is effectively decreased. So what does this translate to in physiology? Decreased stroke volume. This heart, imagine, has 100 milliliters of blood in this cavity, and this has 50 in this left ventricle. I'm just making numbers up, but just to give you a comparison. So incidence is actually higher than we think. It's 1 in 500. This is actually from some older literature. I think everyone quotes these numbers that are actually from like the 80s and 90s. Counts for 40% of pediatric cardiomyopathy. There is a low incidence in young children, but it's still there, probably because they haven't had time to hypertrophy and really develop the symptoms yet. Number one cause of sudden cardiac death in athletes, which we will talk about in a little while, and most of the sudden cardiac death cases are actually occurring in athletes with these patients. Prevalence, so peak hypertrophy, you're going to hit maybe 13 to 20 years old. You can still have it occur as an adult as well, but we're sticking to peds for this topic. Initial studies thought males were affected more. I read an article that was interesting that said, well, maybe there's actually, we don't detect it in women as much because maybe we're not doing as high crazy intensity sports. We're not playing football because there's no football leagues for us yet, I guess. Shut out everything. I'm kidding. Also, I'm not going to play football anyways. I was on the math team. Less female athletes, lower conditioning. They also may present less because they're not like doing this intense, crazy bodybuilding conditioning. So maybe they have it. They just don't have the propensity to really work themselves up and hypertrophy as much. Increased incidence in African-American males. Some data suggesting that maybe they don't get good care, so they don't present to care, so that's why they don't get diagnosed. So just remembering that we have a great mission down here at Carilion to take care of the people who need to be taken care of in this area. Japanese have more apical hypertrophic cardiomyopathy, and I'll talk about what shapes we have of the heart in a minute. So we're living over here today. We're going to talk about sarcomeric and cardiac genetic anomalies, but we'll also mention some other causes of hypertrophic cardiomyopathy. About 50% of cases familial genetic, and then the other 50 sporadic mutations. High disease variability diagnosis is not that easy. I'm sure as general pediatricians, you've all gone, is this a murmur that I need to send? Okay, I guess I'll send it to cardiology because I'm not sure. The spectrum could be you're completely asymptomatic or you present with sudden cardiac death and anywhere in between. Under recognition of very mild early hypertrophy is a known phenomenon. There's variable phenotypic expression. So it's not just one type of isolated septal hypertrophy. It's all these different kinds of things that are happening. The whole heart could be thick. The right side could be a little thick. The septum could be thick. The bottom of the heart could be thick, and the top is not. The bottom of the septum is thick, and the top of the septum is also thick. You can have so many different forms, and it comes in so many different flavors. Here we can see the different kind of presentations that we see. So the sigmoid kind of curve where the thickness is up here, reverse curve where you've got more thickness here, apical where it's all thick at the bottom, and these are a little bit harder to diagnose, and then you've got neutral where everything's just thick as well. And then in our younger population, we're probably going to see this neutral, this apical hypertrophic cardiomyopathy, and this reverse curve. The sigmoidal where it's just thick at the top might be older people. So not all cardiomyopathy is not all hypertrophy is HCM. You can also have hypertension causing the heart to get thick, valvular aortic stenosis, subaortic stenosis, infiltrative cardiomyopathies, and then undiagnosed coarctation. Don't forget about that. And then the athlete's heart, which we'll also talk about in a little bit, but that's a non-pathologic condition that just occurs because you're like loading the heart and exercising and working. Other diseases that will probably be on boards, but I don't think that they're going to test you on hypertrophic cardiomyopathy, but the things that I remember in my head, Noonan syndrome, Pompe disease, you're going to have it present very early in infants, and it's going to be really, really thick hearts, like over 30 millimeters. Other little interesting things, mitochondrial disorders, Leffert, Costello syndrome, infants of diabetic mothers also, when they come out and they're born, they can have very, very, very thick hearts because they've just been growing in response to the insulin that they've been getting. Genetics-wise, so I'm going to show you a couple tables, but the point is not really to digest every single little detail on the table, but to realize there's a lot of genes. I think over 240-some genes have been identified. Dr. Doherty might correct me if my numbers are wrong. I see him nodding in the corner, so it's a good sign. So autosomal dominant, this person's mom was tested and was negative, and so we were waiting on the father to get tested. Many genes exist, like I said. There's sarcomeric genes. There's also some non-sarcomeric genes. If you're wondering, oh gosh, what's a sarcomere? We'll get there, don't worry. Pathologically, so here we can see myofibril arrangement in the heart, sarcomeres, and then going down, we have thick and thin filaments that are attracting and grabbing each other in order to help make contractions in the heart and help bind the heart together and relax and contract. Common genes is MYH7 that I mentioned, and then this MYBPC3. Here, just showing you about 40 to 60% are these sarcomeric mutations, 25% not sure, 10% it's because it's some other syndrome that's causing it, some other underlying cause, like a glycogen storage disease, mitochondrial diseases, Noonan's, like we talked about. Here, just pointing your eye to the beta-myosin heavy chain, it affects the sarcomeric thick filament with this MYH7 mutation, which is on chromosome 14. Here you can see the thin filaments affected, the thick filament, the Z disc, the intercalated disc, just so many different things can be affected. There's a lot of data that we found. Sarcomeric mutations here, just blowing up this picture right here. It's this actually beta-myosin, this heavy chain head here that's having the mutation when it's making cross-links. And then here, I thought this was a really nice picture showing you there's too many engaged cross bridges. There's too much linkage. Everything's overlinked versus like dilated big hearts that are burned out where you're just not getting enough contractility. This is the opposite where everything's like, hey, I'm really excited to contract, and you're trying to keep the walls of the heart apart. Histopathologically, changes that you're seeing, fibrosis here, and then also hypertrophy of these myofibers as well. It's just myofiber disarray is what it's been described as, just chaotic craziness. And then here you can see a growth path slide with the thickness, and you can see this mitral valve that's trying to touch this septum here. So pathophysiologically, we talked about acceleration of this going on in the teenage years of growth. You have a lot of different things going on when the heart gets thick. You have increased myocardial oxygen demand. There's more cells. There's more there's just more everything in order to need to get oxygen to these cells. Compressed intermyocardial vasculature, remember that the heart has to perfuse somehow. It's got little blood vessels going through all these muscles. These poor little blood vessels, like the capillaries that are actually going through the meat of the heart, are going to be compressed. They may have low flow because they're crowded by all this muscle. There may be a reduction of blood supply due to this. They can have abnormal vasomotor responses and vascular remodeling. Some of the mechanisms that have been postulated to occur are actual myocardial ischemia, mitral valve involvement, and diastolic dysfunction. Just a review here in normal intracardiac pressures before I talk about obstruction. So just remember, your right atrium lives at a nice, happy little like 0 to 4, 0 to 5. It's your 0 point in the heart where all the blood is draining in. Blood only flows downhill. The only thing that I know that goes uphill is the New River and the Nile. So like blood follows physics properties. It flows downhill. The right ventricle lives at a pressure maybe 25 to 5, about a quarter to a fifth of the pressure of the left-hand side in an adult. Left atrium pressure is a little bit higher because pulmonary venous drainage is here, so about 5 to 10 millimeters of mercury. Your LV, the inside of this cavity, should be the same blood pressure as your arm if you're measuring it out here, because this is the blood vessel going to your left arm. But if there's an obstruction here, or an obstruction here, or an obstruction somewhere along here, this pressure may be very, very high, and it's trying to actually resist and get out against a thickening area in the heart. So here, this is what we've talked about as the left ventricular outflow tract, basically the part of the ventricle where the blood basically escaping and trying to get to the heart, just showing you this kind of anatomy in this narrowed area here. Imagine that area kind of as a cylinder, and remember the properties of physics with Poiseuille's law where we talk about resistance being inversely proportional to the radius of the force. So remember, the smaller a tube, the smaller a pipe, the higher the flow going through it, the higher the resistance. If you've ever sprayed someone with a garden hose, remember if you decrease the effective orifice, you're going to shoot your velocity of water or whatever out at a much higher jet, higher speed, higher, trying to get against a higher resistance. So this mechanism of obstruction, some people have no obstruction at rest, so you may not hear a murmur because there's nothing that's going on. It's not bad enough until their heart's racing, their heart rate is up, and their heart is actually trying to touch each other. Sides of the heart are actually trying to touch each other. You can have, so basically the left ventricular outflow tract area is contracting. Like we talked about, the effective diameter is decreased. Blood has to rush really fast to get out of there. Louder murmur in more hypercontractile states, which we'll talk about as well. So what we call this is dynamic outflow tract obstruction, because you're not obstructed all the time as if like you had a rock hard aortic valve sitting there. You have muscle that will get squeezed and then will relax, squeeze and relax. So it's a dynamic pattern of obstruction that we see. There's some theory saying that the mitral valve leaflet kind of gets sucked into the left ventricular outflow tract. Remember, I showed you the relationship, the anatomy of the mitral valve. It's basically sitting there looking at the left ventricular outflow tract. There's some theory that as blood is rushing out, there's enough of a vacuum effect. You suck that anterior leaflet of the mitral valve in, and you're in a phase where your mitral valve should be closed. If you're pulling apart the leaflets, you're also getting mitral valve regurgitation at that time. This mitral valve is literally sitting there in the left ventricular outflow tract, blocking blood getting out of the heart. And then when everything relaxes, it goes away. Cardiologists get very excited about this kind of stuff. And then you have hypotension occurring because you're not getting good cardiac output, basically. This is what we'll see on an echo. Just, it's all right, you don't have to learn how to read an echo, but here's a graph. These are all graphs. This is time, and this is velocity. This is somebody at rest. The blood's not really struggling to get out of here. It's nice, 1.6 meters per second, nice and happy. Here you can see in the beginning of systole, low blood flow, not bad, velocity is not bad. Heart's really squeezing in on itself, acceleration of this velocity, and then really trying to shoot it out there at the very end when everything's very narrow at like 6 meters a second, which is pretty fast. So we divide things based on, are there no obstruction at rest? Is there a labile obstruction, or is there some baseline obstruction? We turn our velocities into pressure gradients, or basically the difference of the pressure inside the left ventricle and what's beyond the obstruction in the aorta. And then looking at outflow tract gradients, if we're greater than a 30 millimeter pressure difference between the inside of the ventricle and the outside, that's concerning. There are things that we can do in order to modify that. One of the other things that's affected is cardiac diastole. Diastole is, I think, very underrepresented, but a lot of stuff happens in diastole. The ventricle's relaxing, AV valves are opening, The heart is filling at this point. The atrium can give a little extra kick to fill the heart, and you have equalization of left ventricular, left atrial pressures and diastole. Basically, if a heart is really thick, think about it like a really, really thick balloon that you're trying to blow up versus like a really thin balloon where you can just blow it into whatever shape. Here's a balloon with very, very thick walls, very, very thick tension, and you're trying really hard to blow this thing up. And in diastole, when it's relaxing and trying to fill, it's like, sorry, I can't do that. I'm really, really thick, like a bodybuilder who's like just tense all the time with their muscles. The coronary is also perfused in diastole because you can't really perfuse the heart when it's squeezing down and banging down in systole. Everything has to be relaxed to let blood flow actually through. About 80% of patients have some diastolic dysfunction and have decreased myocardial relaxation, which is the big thing in this disease process. Like I said, the heart is thick, hypercontractile. It can't fill as easily. Your coronary perfusion, there's a couple different thought processes about how this occurs. Some thought processes are those blood vessels are just getting squished as they're traveling through the heart muscle as it's contracting. You could also have more fibrosis as well. That's what leads to this typical LV strain pattern is this T-wave inversion because you're having ischemia actually occurring. So outcomes on this are fairly variable. You could have people who have absolutely no symptoms. You know that they have hypertrophic cardiomyopathy, either gene testing or if there's a significant family history, maybe you're not somewhere where you can test and you're worried and you're going to follow these people. They may not need anything. Some people may have mild symptoms and you don't need to do anything. Some people actually can have heart failure type of symptoms, which is a bad prognosis, meaning if your ventricle is not contracting very well, then your heart may be burned out. And then you're dealing with another disease process of dilated cardiomyopathy. And then other things that you may see are people who don't even meet criteria to do surgical therapy on them or different medical therapy. There's some newer talks about using pacemakers in order to help them. So natural history of non-obstructive, if you're not obstructive and your heart's thick, okay, you probably have a good prognosis. Hopefully you're not going to collapse your heart in on itself when you're doing some activity. Obstructive obviously needs some treatment. This is where the HOCM comes from and the hypertrophic non-obstructive cardiomyopathy comes from. We talked about this burned out HCM. Here's this interesting data, 0.8 to 1.5% of sudden cardiac death per year, and that risk goes up with aging as well. Some people develop heart failure, maybe about 10 to 15%. Rare reports of mitral valve endocarditis, but it exists. I still don't think that means I'm going to SVU prophylaxis people because they don't meet criteria. 30% of older patients get AFib, 25% get autonomic dysfunction, disability to regulate blood pressure. That's pretty bad. All right, so our brains are all full. That was enough of the physiology stuff. Now we'll get to the fun, actual clinical stuff. So symptoms, what can you see? Nothing, or syncope with exertion, like this kid had, chest pain, dyspnea on exertion, which actually is related to having diastolic dysfunction because when your heart is not filling very nicely, it's causing a back chain of resistance. Left atrial pressure increases, that pushes back on the pulmonary veins, pushes back on the lungs, you might get some pulmonary edema, you're getting short of breath. Palpitations and arrhythmias, AFib, PVCs, non-sustained VT, dizziness with activity, sudden cardiac death, day-to-day variability of symptoms, so can lead to under-recognized disease. If I'm seeing patients in my clinic who are saying, oh, yeah, you know, I had syncope on the field, that's a lot different. I've seen many patients who go, no, no, it was actually after I went and sat down, I was dehydrated, and then I kind of sort of fainted, but I didn't really. I just kind of got dizzy and woozy. And I've had other patients who are like, oh, yeah, it happened before. What I'm asking for is when your heart is trying to work, when you are running, when you are asking your heart to basically floor itself and go 0 to 60, did it go, no, sorry, I'm not going to do that, and I'm going to pass out. So I want to know, are these patients actually having symptoms at activity? While you're running down the field, peak speed, has anything ever happened to you? Dizziness, chest pain, shortness of breath, hypotension in that activity scenario. There are people who have unexplained syncope, though, without doing anything, and those people actually have a worse prognosis. Family history questions that I'm going to ask may not be as extensive as genetics is going to ask, but still really important to remember your questions. Anybody with unexplained sudden cardiac death, anybody in some kind of anybody who was like a healthy person and they just died suddenly without any reason, anybody with some early cardiac death, anybody with known actual hypertrophic cardiomyopathy or any other inheritable heart disease, anybody with congenital heart disease. So just some of the screening questions that I'm going to be starting to ask. Clinical exam findings, you can have a bifid carotid pulse, a prominent A wave on your JVP if your left heart is so sick that it's affecting your right heart. Double apical impulse, which I thought was kind of interesting because when you have your first point of maximal impulse, what you could have is that atrial kick from the top at the end of diastole, pushing into this thick left heart and giving you another knocking feeling at the apex, basically. S1 can be normal, S2 usually fairly normal. If they have an S3, they have a gallop, they're in heart failure, and then an S4 from hypertrophy. I will sometimes see people describe murmurs in different ways. Just remembering for the residents, murmur grading, they say a 1 is just after cardiologists cannot hear it. If you rotate with me, I'm going to disprove that because you got ears and they work, and I know that. So a grade 2 murmur, a little less loud than the heart sounds. Grade 3, same intensity. Grade 4, they better have a palpable thrill. Just remember that, because I have seen people who people thought they graded it a 4 out of 6, but they didn't actually have a thrill. 5, you can hear a murmur with the heart, with the stethoscope cocked off the chest. 6, you can hear it outside with, like, basically just at a distance from people. I've never actually heard that about a murmur. Hypertrophic cardiomyopathy here, again, crescendo, decrescendo murmur, which is different from a murmur of aortic stenosis, which is going to be more of a crescendo type murmur. And then here, with squat and hand grip, and then standing or Valsalva, I like to think about these not as memorizing all these little details, but thinking about what's actually physiologically happening in the heart. So when I'm squatting, I'm having gravity affect myself. All my blood is closer to my heart, so it can fill my heart easily, and I'm pulling apart the walls of my heart, basically. So it's not going to slam shut on itself as much. It's not going to have as much of a murmur. Same thing with hand grip. With hand grip, what I'm doing is I'm increasing afterload. I'm increasing my blood pressure, and I kind of, it's a hard concept to understand, but in my mind, I think of like, maybe there's a little man standing here like this going, no, you can't contract. I'm not going to let you, when you're increasing your hand grip and trying to resist having this area slam shut. When you're standing, gravity takes effect. Blood is emptying out of your heart. Your heart is less full, so the walls can slam against each other and make more of a murmur. With Valsalva, you're basically impairing your preload. You're impairing your return to your heart. Your heart's also empty. So think about it, full heart, less murmur, empty heart, more murmur. And that's also the concept of cardiac preload, basically. You can also have a mitral regurgitation murmur if they have significant mitral regurg, which would be a systolic, holosystolic murmur heard at the apex. And then you can also have an aortic regurgitation murmur, which you can hear, which is a diastolic murmur, but that's not very often, maybe in about 10% of patients. So here are the maneuvers that we talked about. So anything that increases preload, like our squatting maneuver, basically, remember, decreases your murmur. Hand grip decreases your murmur. Valsalva and standing will increase your murmur. After a PVC, you have increased contractility, a big oomph that just happened in the heart, and you can have an increased murmur then too. You don't have, if you're worried about a patient, obviously send them to cardiology. There's no worry. If you have a question, call me on the phone, call one of us. We'll be happy to walk you through things. Myocardial ischemia, so talking about this, this is basically what we talked about with the coronaries being small, not really growing well, inadequate number of myocardial capillaries, increased diastolic coronary filling pressures. Maybe you really have to overcome a lot of pressure to fill the coronaries with blood, and you get some kind of subendocardial ischemia. This is just in there so that way we can revisit our EKG. So we mentioned we had our LV strain pattern and our T-wave inversion. You can either have left or right axis deviation. This child actually had some leftward axis because the heart was so thick on the left, all the factors and all the forces were going towards the left side. You can have left atrial enlargement over time. You can also have conduction delays, heart block, prominent Q wave, AFib, pre-excitation is a poor prognosis, AFib in older people. And then screening Holter is also part of this evaluation, and you may have to do Holters at other intervals of these patients to figure out, is there any underlying funny heart rhythm going on? And just for the residents, the Holter is only a 24-hour capture. It's a recording that goes the entire time. The machine never stops. An event monitor is when you take home for a several period of weeks. If you have a symptom, you push a button and it records something, but it's not live recording all the time. So Holter captures all my heartbeats in 24 hours, kind of like Telly on the floor, basically. So here, just going back to our lovely EKG, remember T-wave inversion here, lateral leads. You actually see some T-wave inversion here in 1 as well, funny-looking T-waves in 2 and 3 as well, these big T-waves here. And then we also talked about a leftward axis in this kid. Just remembering that for you guys. So echo findings, like I said, it's not really a cardiology talk, but the things that we will see on echo. Left ventricular hypertrophy, long-standing cases, the left atrium could be big, heart's not relaxing, small LV cavity size, things that we've already mentioned, dynamic obstruction, systolic intermotion of this mitral valve, and then also decreased mid-aortic flow and partial closure of the aortic valve in mid-systole, because a lot of blood may not be escaping the heart. The aortic valve is like, well, nothing's going through me, I guess I'll close, which is not good. So here, just going back to review this child's echocardiography, you can see again here, very, very thick heart. This posterior wall thickness was, I think, almost up to 16 or 17 millimeters, and the septum here was basically, I think, like 28 millimeters. So it's very, very thick heart. When I talked to one of my outside facilities, it was not the thickest heart that they had seen, which I was surprised, but it's a fairly thick heart. It's a fairly classic example. His EKG was diagnostic. All of us in cardiology, we were looking at the EKG going, oh no, I know what this is. The echo was confirmatory, so just keeping that EKG in your brain. There are little caveats about some percentage of patients can have some of these EKG findings in high-intensity athletes, and maybe it could be normal, but that's even a point of contention in cardiology. That's even a point of debate. I've been with my colleagues. We've walked in, looked at EKGs, gone, oh, is this okay? Is this not? What's our next step in testing? So there's even a lot of variability and debate between cardiologists. So if you're not sure, it's okay. Call us up and you'll be happy to see the patient. Role of MRI, we don't have MRI services for peds at this hospital yet. Dr. Dunsmore, maybe we should get that. That would be good. Role of cardiac MRI, non-urgent, can help you define anatomy better. What we look at is late gadolinium enhancement, basically seeing are there fibers that are fibrosis areas in the heart where you're picking up some kind of signal. But it's not really very helpful because 5% of athletes can actually have weird findings on their MRIs as well. So that's why it's not really in part of the actual real recommendations for diagnostic evaluation as first steps. Exercise testing. This is done usually through pulmonary in some centers. We do this here in pulmonary in the adults. I don't think we do this in pulm here with pediatrics, but this is a different kind of exercise test. It's not a test where you're actually running on a treadmill and just looking at electricity. These people are wearing a mask to gauge how much oxygen exchange is occurring and seeing how well they're performing. It's probably, you may have seen it on TV, like the Gatorade mask, high-intensity athletes who are running. They're basically trying to look at what's called their VO2 max, or maximal oxygen uptake. The only thing in this that I thought was really interesting, people who have hypertrophic cardiomyopathy, their numbers might be normal, might be decreased. Athletes, they have a really, really good VO2 max. They are conditioned. They have good endurance. So trying to figure out, is this an athletic heart? Is this not an athletic heart? This could be a point that could help you. Obviously with a very controlled environment, because you don't want them to syncopize if there's actually something going on. So exercise testing, I think, is also something that we in cardiology approach with a very thoughtful brain, making sure that we're not going to cause any harm to the patient. So cardiac cath can be useful in pre-op evaluation, measuring gradients, looking at the heart itself. Some centers can actually do exercise cath. They'll put you on a recumbent bike and then check your pressures in your heart. Okay, almost there. Okay. Nothing, dead silence. I bored you all. Talk. All right, so pediatric cardiac sudden death, lots and lots of causes here, as we can see, things that we've mentioned before. Hypertrophic cardiomyopathy here is our structural cause. Long QT syndrome, WPW, Brugada, other things like that, which we should keep in the back of our head too. A third of the cases, like I had said, sudden cardiac death in athletes, this data is from 2007. I've seen some reports now that are up to about 40%, 45% of sudden cardiac death in athletes being due to hypertrophic cardiomyopathy. But this is like the #1 cause. Secondary, you can see some coronary anomalies is another cause. Sudden cardiac death is complicated. There's a lot of factors that are involved. Fibrosis, scar tissue, how severely thickened the heart is there non-sustained VT, are they going to a funny rhythm, is there family history, unexplained syncope, so many different things that go into this discussion. Lots of risk factors. Major risk factors, if you've had a cardiac arrest before, then you have a propensity to have another one. If you've got really, really bad looking sustained VT that's going on longer than 30 seconds, yeah, then maybe you have some propensity to have problems as well. Family history, premature death, family history is really important. Unexplained syncope, really, really, really sick hearts. People who basically when they exercise, their blood pressure drops because they're not getting any blood out of their heart. Yeah, that's not good. You'll probably die if your blood pressure drops. Non-sustained spontaneous VTAC as well. Arrhythmias, in these, you can see a lot of arrhythmias. You can see anything from the gamut of little PVCs to actual non-sustained VTAC and VFib like we saw with this kid. AFib, AV block, SVT, lots of different arrhythmias that we can see. It's usually the ventricular tachycardia, ventricular fibrillation, that's the thing that's going to kill somebody, because at that point your heart's not doing any effective beating, any effective contracting, you're not getting blood flow out. So this here just zoomed in, talking about the pathophysiology again. So you'll have abnormal vasodilation response in these patients, the outflow tract obstruction, diastolic dysfunction, all this leads into hypotension. This autonomic dysfunction can occur. You get myocardial ischemia, your heart's not happy, you get VTVF. This is just remembering the PALS algorithm for you guys. So remember, this kid had VS, pulseless VT, started CPR right away. They brought the AED, they shocked. Is this a shockable rhythm? For them, it was when the actual defibrillator got there. They were in VF, it was shockable. Remember, pulseless VT or VF, shockable rhythm. And then other things that you can do when you're running your code, epi every 3 to 5 minutes, then giving amio or lidocaine as well in order to help arrhythmias and then treat reversible causes. So screening, a loaded topic as well. If you got known first-degree relatives, then yeah, you need to have a first-degree relative screened. You need to find the index case in order to genetic test. Can't be like, oh, Bob out there somewhere had it, so can you test like Joe here? Probably not going to work insurance-wise. You need to figure out who the person was who had it, see what their gene testing was, see if you can test them, figure out what the abnormality is. 25% of patients may actually have some echo evidence of hypertrophic cardiomyopathy early on of these relatives. Sports, oh my gosh. If you ask like every cardiologist, they're all going to have a different opinion. It's a very loaded topic. U.S. guidelines, we do only history and exam, and I thought this was really interesting. The Europeans have actually developed an EKG screening. They do this in Italy. There's some legal mandates about sports participation. This has been going on for 25 years. So they actually do get baseline EKGs and help screen people in and are able to find disease more. In May, I participated with Dr. Perkins and Dr. Miller in a cardiac screening event that we ran for patients and families in order to help try to pick up abnormal EKGs. Hopefully we'll gain more emphasis next year and maybe be able to get some echo technology there as well. It's a very loaded topic. I think that no child should have to die. I think no parent should have to look at their kid and be dead. I don't care if this incidence is 1 in 500. Tell that to the family who's lost their kid. There's nothing you can say. Don't quote them numbers. I mean, so it's a very loaded topic. Athlete's heart, so this is a fairly big challenge here, trying to figure out, okay, is this heart a bad heart? Is this heart just a thick heart because of being an athlete? This is where we may be in a gray zone. Is the heart just a little thick, 13 to 15 millimeters? Your LV cavity in an athlete's heart is not going to be small. You're not going to have weird EKG patterns. Your heart's going to fill normally. The things that we can do in order to see, is this an athlete's heart or not? Tell them to stop exercising, which may be really stressful for some patients. Tell them to stop exercising like nothing for 3 months, recheck their echo and see, has their LVH regressed? So if it's regressed, then it's because they're conditioning. It's not because it's actually HCM, they had substrate to be thick. Differentiation, like I said, have the athlete stop exercising. You can also do this exercise testing. But there's a lot of gray zone in here. Okay, last thing, almost done. So hypertrophic cardiomyopathy treatment, goal is to reduce symptoms, reduce our sudden cardiac death risk, help people deal with the awful physiologic and pathophysiologic changes that are going on. Medication management is aimed at decreasing heart rate, decreasing contractility, getting the heart to not touch itself and obliterate its cavity, giving vasopressors when you're acutely sick like phenylephrine, preload sensitivity, giving volume, making sure they're hydrating well, 80 to 100 ounces of water a day. That's like 5 to 6 of the 16-ounce water bottles as a nice bare minimum. I tell people a little bit over because I don't expect them to drink that much, so maybe if they shoot like 2/3 or 3/4 of that, hopefully they'll be good. Surgical and cath interventions are designed to reduce septal thickness. There is some dual chamber pacing that can be done for non-surgical candidates, which I think is a discussion far beyond pediatrics today. Placement of an AICD is a very weighted decision, and they're restricted from competitive sports. For some people, this is awful. This is like their lifeblood, so they're coping with losing this important part of what they do, and they've also had an awful heart arrest or they've had an awful diagnosis, so there's a lot of psychological issues, depression, things that can happen to patients afterwards. So treatment algorithms, there's a lot of information here, just showing you there's a lot of different pathways you can go down here. Either you're asymptomatic and we're screening you. The guidelines for screening by the American College of Cardiology every year to every 18 months or so while they're going through their growth acceleration phase in the teenage years. If you don't have any heart obstruction, if you have heart obstruction, then you might be starting with beta blockers or calcium channel blockers. If you've got heart failure, you can use heart failure therapy, different things. Or if you have arrhythmia, different things. If you have issues with left ventricular outflow tract obstruction, depending on what's happening, what the heart looks like. Medical therapy, so beta blockers and calcium channel blockers are decreasing contractility. They're decreasing the heart rate. When these people get tachycardic, the heart is really contractile. It's trying to basically obliterate the cavity. This child, it was interesting. We could actually watch on echo in the ICU and see what happened. When his heart rate shot up to 80, 90, 100, his blood pressure dropped because he wasn't getting good obstruction, and you could see the heart slamming shut on itself. We had to get him down to a heart rate of almost 45 in order to get him to not obstruct and not slam his heart shut. When he came to see me in outpatient follow-up, we were keeping his heart rate around like 50 to 55. So it varies for every patient. It really, really varies, but that was just the extreme case of this one person. We beta blocked him down enough. He wasn't fainting, so that's good because you don't want to beta block someone so far down that they actually have pauses and they're fainting. So it's a fine line of what you're doing here. There's another drug, diisopyramide, which I haven't really seen used in pediatrics a lot. I saw it a lot more in adults over in Seattle at the University of Washington, but they had a big congenital heart disease center there as well. So it's a class 1 antiarrhythmic. It's actually used to treat VT, but it has a negative inotropic effect, so you won't squeeze your heart as much. And then it can also have decrease in contractility, like I said, but there's anticholinergic side effects that can be really, really terrible for patients. So they kind of reserved it as a next-line therapy because of the side effects patients have. You can give it both PO and IV. Remember, I said critical to maintain good volume intake. Mechanism of hypotension, just kind of revisited here. Remember vasodilation. So in the acute phase, trying to get something to bring our blood pressure up and not using agents that will decrease your blood pressure. These are not kids I want on ACE inhibitors because an ACE inhibitor is going to drop your blood pressure. It's going to make it much easier for your heart to eject blood, much easier for the heart to obstruct itself. So that's not what we'll start with these kids. Ventricular outflow tract obstruction, like we mentioned, diastolic dysfunction, like we mentioned. So then a little bit on treatment options here, and not to really exhaust you. There are things that can be done, such as septal myectomy, but this is also something of debate. It's really reserved for people with refractory symptoms to medications. There is some data to say perhaps these patients get less arrhythmias and do better, but the hypertrophy can regress. Even if you're cutting out the heart muscle, it can always come back. So it's really a loaded decision when we're trying to decide who goes for myectomy. It's not as clear and dry as, oh, okay, here's this, here's that, here's all these criteria, let's go do it. Alcohol septal ablation in adults, that's not something we do in kids. I have seen this done in adults where they basically are giving, taking a coronary catheter down a coronary artery, giving alcohol and causing an autoinfarct, basically. And then they'll go to the ICU afterwards. We'll monitor them. One of the cases I saw, the woman actually needed a pacemaker afterwards because she burned out her AV node. The AV node lives in that center of the heart where the septum is. You burn out your AV node, and that doesn't work. You need something to help get electricity from the top of your heart to the bottom. And then dual chamber pacing is something that's been talked about recently, just trying to actually stimulate the heart in a way where you're pulling the walls apart at different times in the electrical cycle and not allowing it to collapse in on itself. Myectomy, like we talked about, is a risk of heart block, needing a pacemaker, and then some studies that say myectomy might improve symptoms. Here we can see trying to cut out a little cute piece of the heart here. And we generally reserve this for septal hypertrophy greater than 30 millimeters, so a very, very thick heart. Defibrillator placement, remember, for the residents, pacemakers are going to give you a nice heartbeat, going to regenerate my QRS, my P wave. They're not going to defibrillate you. Defibrillators are a hard stop in order to reshock the heart and get everything started and going again. All defibrillators have pacemaking capabilities because once you shock the heart, you're probably going to have a period of asystole where the heart needs to wake back up. So they automatically are encoded with some pacemaker technology in them, but not all pacemakers are defibrillators. So individualized plans for patients, it's really shared decision-making because you're sitting here talking to these patients going, guess what, we're going to put a shock box in. It's not, hey, we're going to do this, go away. People on the other side are going to be really afraid. I'm going to get shocked. I have something in my heart. There's something in there. This is a true thing that we see. So a lot of need for having good counseling services. What we talk about these are primary and secondary prevention devices. This kid got a secondary prevention device because he already tried to die once. So we're not trying to prevent anything. We're trying to prevent the second thing that happened. Primary prevention devices is if you're trying to prevent somebody from having a first attack. And then AICD placement algorithms here. As we can see, this is from American College of Cardiology. Have prior arrest, okay, shame on me, shame on you if I miss this. You're getting a device. You're not walking out of this hospital without an ICD. That was this kid's case. History of first-degree relatives with sudden cardiac death, really sick heart, unexplained syncope. I think this is like level of evidence 2B. There's ICD is reasonable for the, or sorry, it's 2A. ICD is reasonable. Non-sustained VT, abnormal blood pressure response. They don't recommend an ICD. ICD can be useful if there's other risk factors present for sudden cardiac death, but really role of ICD is uncertain in certain cases. This is, so here nearing the end here, just this is the Bethesda conference guidelines for sports participation. I've seen this in a lot of different places. Reading this graph, there's a static component of activity and then increased dynamic component as far as your max oxygen consumption. I think this is funny. Like, canoeing and kayaking is more high intensity than American football. I'm like, okay, that's kind of weird. Speed skating is worse than doing rodeo, apparently. Ice hockey is worse than doing archery. It's interesting and funny. These kids are going to be allowed to do these competitive sports, golf and bowling. About it. So I'm sorry. It's really terrible. It's awful for these teenagers. Yeah, I mean, we do not want them doing activity. This kid, his mom got him an Apple Watch to try to test and see what his heart rate did. So they ran around at home a little bit, and then when it got to like 110, she was like, stop, stop, stop. I don't want to see. He wasn't dizzy, nothing happened. She was like, stop, don't do that. Another time after he had gone home, he went out on the basketball court for a little bit. I don't think he was as hydrated, and he actually did get some dizziness symptoms, and he was like, okay, I'm stopping. I'm not doing this. So definitely very fine-edged sword with the kind of activity they can do. So in summary, this is the #1 most common genetic cardiomyopathy, #1 cause of sudden cardiac death in athletes. You have abnormal fibrosis really messing up the actual architecture of the heart. Obstruction is dynamic. Murmur, remember, anything that increases your volume in the heart is going to decrease your murmur. Anything that decreases the volume in your heart is going to increase your murmur because your heart's going to try to slam shut on itself and touch the walls of the heart together. Risk of ventricular arrhythmias can occur at any time, actually. So there is some data to say that patients can have it just at any interval, not necessarily with exercise. Myectomy is reserved for refractory symptoms. AICD placement needs to be considered. And, yeah, we made it. Day 30. You guys can go back to work.
Well done. All right. We have time for one question. Anybody in the room have a question or want to make a comment?
Your brains might be burned out by now. The diet part.
Asma, great talk. This is a disease process I hate in all age people. But do you have a feel, so on my super paranoid days, I want to do an EKG in every single sports physical I do, but I don't have a good idea, and you probably might, about is there a correlation in septal hypertrophy growth with Tanner staging, like in our 13, 14, you know, Tanner 3, 4-ish kids? How sensitive is that EKG with left heart strain?
It's fairly sensitive. It is actually fairly sensitive because that's an abnormal pattern. You're not going to see in many people. There is some literature to say like 5%, I think, of African-American, very high-intensity male athletes might have some funny T-wave patterns, but otherwise, if you see that, it's fairly diagnostic. The growth acceleration is going to be increasing as you hit that puberty stage because that's when you have all your extra growth and factors happening. I think, you know, I guess my personal opinion is everyone can get at least one EKG in their lifetime, so that might not be a very cost-effective solution, but then the other end of it is like the cost that you have in the ICU of the kid on this machine, on all these services, on all these therapies, that's like several $100,000 stay versus the cost of a quick little EKG that we did. If you are suspicious about the murmur, yeah, good reason to do an EKG. If there's good family history, do an EKG. If there's weird history, like, hey, I fainted, I think it's fine to do an EKG, I think, but you're medicine like me, so, like, we will all do an EKG and be happy with it. So I think low threshold to do an EKG if you're suspicious, low threshold to refer if you're suspicious as well. So.
Thank you very much.
Thank you.